All right, I am going to start chapter 17, the high risk neonatal nursing care. This is the one that we actually did in class via Zoom that I promised that I would give you guys a recorded lecture on. So, our objectives is we're going to talk about the care of the preterm newborn, the complications associated with the preterm newborn, such as respiratory distress syndrome, hyperbilirubinemia. We're going to talk about the causes of retinopathy of the prematurity. We're going to talk about the post-term newborn, the newborn with meconium aspiration syndrome, small for gestational age / intrauterine growth restricted newborn. They are two different concepts, but there's a lot of connectiveness with those. The next one is large for gestational age, the newborn born of a mom with diabetes, and care of neonatal infections. And we're going to discuss a few selected congenital anomalies. I had you guys watch the video here of the NICU baby, and we went over questions that related to the NICU baby, so I'm not going to replay this video, but definitely go back and take a look at it. It kind of gives you an idea of what we're dealing with and some of the issues and some of the concerns. When you're watching the video, think back to the questions that we talked about. Think back to what are some nursing diagnoses that you would give to that baby in that situation. And sometimes something you want to think about is not necessarily nursing diagnosis with the baby, but what about the parents? Are the parents part of that care plan? So your preterm neonates, and this is just the guidelines that tell you if they're very premature, or late premature. Some complications of the preterm neonate. The complications, the big one is respiratory distress syndrome. But remember, respiratory distress syndrome doesn't just affect the preterm, it can affect all neonates, but the preterm neonate is at highest risk for respiratory distress. Bronchopulmonary dysplasia, which is a stiffening or hardening of those newborn lungs, and this newborn needs to be intubated. And aspiration, not having that mature gag reflex, that's sucking and swallowing. Remember we talked about that. So that inability is going to put that newborn at high risk for aspiration, which think that aspiration can go into the lungs. And remember, these newborns have an increased risk for infection already. That sets the stage right there. So then the aspiration can lead to pneumonia. Pneumonia increases the risk for respiratory distress. Respiratory distress increases the risk for the baby to work harder and use more of its calories. It's going to have a lower blood sugar and have thermoregulation problems. So you kind of see how that all works together. Apnea of the prematurity. So the big key with that is remember that greater than 20 seconds point. Retinopathy of prematurity, in the biggest key and takeaway is it's associated with the oxygen administration. So really monitoring those pulse ox, keep an eye on the ABGs, looking at the baby. How's the baby breathing? Can we start weaning the baby off of this high flow oxygen? Patent ductus arteriosus occurs when the ductus arteriosus space reopens, kind of in a compensating mechanism due to neonatal hypoxia. And another one we talked about was necrotizing enterocolitis, which is like sepsis of the GI, and that is you can see necrosis and perforation of the bowel, and you want to really be careful. You'll see that more common in the enteral feeding newborn. And remember, we talked about the breastfeeding mom, the breastfed babies have a decrease in getting enterocolitis. assessment findings pretty lengthy. We went over this, we talked about this, and some areas that I would hone in on would definitely be your low tone. So we'll start off with your hypotonic muscles, which you'll see that kind of transcend with their reflexes. So weak grasp reflex, decreased sucking and swallowing, very lethargic, poor tone, and you'll see periods of apnea, anything greater than 20 seconds or longer. Their skin is very thin, translucent. You can see the veins underneath. They are increased risk for hypothermia. Really, their skin's at risk. You want to really make sure you're protecting that skin because it's so thin with breakdown. The preterm is going to have an abundance of lanugo on their skin. Where else are I going to go with that? There's something else I was going to say with the skin. Oh, you're going to see a lot of vernix. I was trying to think there. I'm trying to give you an idea of you're differentiating between your preterm and your postterm. So you're going to see a lot of lanugo, and as you noted in that video, you're going to see a lot of vernix versus your postterm. You're going to see very little lanugo and very dry, cracked skin. I think everything else we kind of pretty much talked about, but definitely go back through here and revisit this. So the nurse in the NICU is assessing a neonate delivered at 32 weeks gestation. Which pathophysiological manifestation is the nurse's greatest concern? So all of these are a concern, right? Because it said which is the greatest. So it tells us that everything is a concern to us, but we want to know which is the greatest concern. Absent or weak reflexes, did we say that they could have that? Absolutely. Presence of a heart murmur? Absolutely. Apnea 20 seconds or longer? Yes, they can have periods of apnea. And low hemoglobin level? Yes. But what is the greatest concern? So think your ABCs, your apnea. Additional complications, we talked about everything there. So again, think of what are some nursing diagnoses. Medical management. So you're going to be managing everything from a systems perspective, airway, heat, protecting the skin, cardiovascular, monitoring ABGs, administering oxygen, intubating, monitoring INOs, monitoring and maintain, for bleeding, low blood sugar, infection, administering the surfactant, administering feedings. Your labs would be the same that you would see drawn for any of your patients that are in a critical care setting, including the bilirubin. Do culture, blood cultures. Always remember, you have blood cultures ×2 ordered. You have vancomycin to be hung. First time, what do you need to do? Right, so you need to draw that first blood culture and then initiate your antibiotic. So go back, review those labs that I posted on Canvas, and not just knowing their numbers, but knowing what they're used for, right? So where we talk about the PT or APTT, so if that baby is on heparin, which lab would we be monitoring to be making adjustments to the heparin infusion? Right, the PTT. The labor and delivery nurse is present for the delivery of a premature neonate. Which action by the nurse is most important? Stabilize and transfer the neonate to NICU, and this is the first thing that you're going to be doing. Review pregnancy history for risk factors, maintain fluid and electrolyte balance, or provide a neutral temperature environment. So hopefully we are saying that we're going to be maintaining a neutral temperature environment. If we wanted to number those, number 4 would be 1. Number 1 would be 2. Actually, probably 4, 3, 1, and 2. The reviewing of the pregnancy history for risk factors that should have been done and prior to that, or we can get that information after we get the baby stabilized. Medications, we're going to talk about your medications. This is pretty much your laundry list of what you would expect to see on your order set. And the one thing I want to draw your attention to is the erythropoietin. So going back to your, probably had it in your ADM 160 when we were talking about your anemias. So think back to your erythropoietin. What is your erythropoietin? It's going to stimulate your red blood cells, and that is going to increase the risk for retinopathy. And remember, we talked about the oxygen increasing the risk, and so is the erythropoietin going to increase it. And I think everything else we talked about. And I like my bottom bullet point here, bringing those parents back. And remember, we've got this baby here, but we have parents that are, oh my gosh, are just absolutely devastated and concerned and worried, rightly so, about this newborn baby. So informing these parents, keeping them in the know of the progress of the goals. Sometimes you'll see in the NICU, you'll see their goals written down for the day, and it'll be just like rest and grow, or whatever their goal may be that day. So assessing for signs of respiratory distress. So your big things is that grunting breathing, which I showed you that video, and if you need to go back and revisit that, it's on another slide. The flaring of the nares, the chest retractions, the cyanosis. The cyanosis is going to start circummal around the lips, maybe a little bit of acrocyanosis, and then maybe generalized cyanosis. And I put down here, decreased body temperature increases body metabolism, which increases the risk for hypoglycemia and respiratory distress. So there's your big hitters again. Maintaining neutral thermal environment. We talked about that. Keeping the head covered, keeping the baby in the warmed incubator, encouraging skin to skin if the baby is allowed out of the incubator, pre-warming, making sure everything that you're using is warmed up. If you're going to be using your stethoscope, warm that up. They actually have their own stethoscope, so they should have their own equipment right at their incubator. Maintaining fluid and electrolyte balance. Strict INO, really strict INO. Everything that goes in, everything that comes out is weighed and checked for balancing, right? We want to make sure that we have what comes in is going out. We don't want to have a deficit or an overload. So you're going to be weighing the diapers. You're going to be assessing the frequency of their stool and their urination, the amount, administering IV fluids as ordered. Monitor those sites for infection because they are another source of infection, any opening. And adding humidity to the neonate's environment. So gavage feedings, you want to check for presence of bowel sounds. You want to assess the abdomen for any bowel loops and discolorations. So what, if you see bowel loops, what is that a beginning sign for? Right, for enterocolitis. Check for gastric residuals by aspirating, but I really want to say the pH, and I'll see if I can find one of these studies to show you. I do know that some of the hospitals, that is their protocol, is pH. Assess for emesis and check stools for occult blood. And if it's been a long time since you went over gastric feedings, please go back and refresh yourself with enteral feedings. So monitoring I's and O's, 1 gram is to how many milliliters? So keep that in mind. You will need to know this. So it's a 1-to-1 ratio. 1 gram is equal to 1 milliliter. And then I gave you this scenario here. So you will have a scenario exactly like this in your exam. However, obviously, it's not going to have the same numbers. So make sure you understand how you get to that. So an infant had 3 wet diapers during the 8-hour shift. The weight of a dry diaper is 15 grams. The 3 wet diapers weighed 38 grams. 28 grams, and 25 grams? What amount in milliliters should the nurse record for the total 8-hour urine? So what we need to do here is set this up with all of your weighed diapers. So you have 38, 28, and 25. You need to subtract the weight of the dry diaper from each of those diapers. So 38 minus 15, 28 minus 15, 25 minus 15, and then add that number up. Or you have 3 diapers. You can take 15 grams times 3, which is 45. That is what you're going to subtract from the 38, 28, and 25. And there I have it done for you. So 38 minus 15 is 23, 28 minus 15 is 13, 25 minus 15 is 10, and your answer should be 46 milliliters. Promotion of developmentally supportive care. So the key to this is minimizing care, clustering the care, keeping the area quiet, keeping the distractions decreased to a minimal, keeping the lights dim, protecting the baby's eyes from the bright lights, especially if they're really premature. So respiratory distress syndrome, it is a life-threatening disorder that results from undeveloped or underdeveloped lungs or lungs that have insufficient levels of surfactant. It usually occurs between the 37 and 39 weeks. The more premature, the higher the risk of respiratory distress. And then I give you a list of factors that would increase the risk for respiratory distress. So think about what we've already learned. The baby born of a mom with gestational diabetes, the baby born of a mom who had a C-section, multiple pregnancies, a precipitous labor. So tests used to evaluate the fetal lung maturity, the one I want you to know is your LS ratio, and know your normals. So an LS ratio greater than 2:1 in a non-diabetic woman, or an LS ratio 3:1 or greater than 3:1 in a diabetic woman are your norms. Complications of respiratory distress syndrome, I think we talked about that already. Characteristics, we talked about that, and there is your video. Another one is edema. I didn't talk about edema. So your tachypnea, grunting, respirations, nasal flaring, chest retractions. So clinical therapy, so you want to answer a yes and no. Is the baby full term? Is the amniotic fluid clear of meconium and evidence of infection? Is the baby breathing or crying? Does the baby have muscle tone? So if you answer yes to these questions, the baby cannot go to the mom, and that baby needs resuscitative measures. So some resuscitative assistance is a warm environment, administration of oxygen and or positive pressure ventilation. You may need to start chest compressions, starting CPR, administration of epinephrine or any volume expanders, or both. So there's a whole host, really depending on what the scenario is. Suctioning the airway, making sure that you're clearing all of the passages. Maintaining a good temperature, so you want to maintain between 97.7 and 98.6. Making sure you're drying the baby really good. That is going to stimulate for breathing. Remember, heat loss is rapid, so really be careful. Any wet, cold environment is going to decrease the baby's temperature quickly. And again, hypothermia increases oxygen consumption, which increases respiratory distress and decreases the blood sugar. So think simple to complex. Position the airway. The lungs must be inflated with positive pressure, and an ET tube may be needed. So again, airway, try to go simple. I mean, we're not going to go sticking an ET tube in immediately. Let's try, maybe we're just clearing the airway and giving a little bit of breath, a little bit of oxygen might arouse the baby around for breathing. Medications I want you to know. Oxygen is the most often used medication. A lot of times we forget that that's a medication. Epinephrine. Epinephrine would be used if there's persistent bradycardia. Sodium bicarb would be used to correct metabolic acidosis. Dextrose would be used for severe hypoglycemia. In the critical care setting of the newborn, it's dextrose. In the normal mother-baby unit, it would be initiating feedings. Naloxone, reversal agent for narcotic depression or respiratory depression related to narcotic administration. Volume expanders are used for hypovolemia. Examples would be lactated ringers or normal saline. Whole blood and packed red blood cells for blood loss, anemia, extreme anemia, but usually for your blood loss, like we saw in that video. Prolonged resuscitation or shock would be dopamine. So just make sure you know your meds. The last one is your surfactant agent. Your surfactant agent is administered by direct intratracheal instillation, and it is lowering the surface tension that forces, lowering the surface tension forces that cause the alveolar to collapse. And your agents could be poractant, calfactant, or baractant. Again, what do your surfactant agents do? They lower the surface tension forces that cause alveolar collapse. Clinical therapy. Again, the goal is to get those antenatal steroids into mom prior to delivering, at least 2 doses. Getting that surfactant in, delivered via the ET tube, and then supportive management, maintaining the blood gases, pulse ox, correcting any acid-base imbalances, temperature regulation, nutrition, and infection. So that's a big key one. That supportive management kind of covers everything: airway, temperature, nutrition, infection. And morphine is used not only for its analgesic use, but also for its sedative effects, as you saw in that video. So I thought that video was just really good because it kind of covers everything we talked about. I told you to make sure you know your acid base. You'll have a question for acid base, and I had 2 examples here. So if you need to revisit these after you've gone over how to do it, I'll certainly pause that. I'm going to continue through. So the first one, you had your pH is 7.24. Your PCO2 is 75. Your HCO3 is 28 for number 1. Number 2, your pH is 7.5. Your PCO2 is 36. And your HCO3 is 32. And there will be your answers. I'm not going to play the video, but your congenital heart defects, your first one we're talking about is patent ductus arteriosus. And it occurs when the ductus arteriosus remains open at birth. It normally closes within hours, but it can take as long as 96. One of our complications we're concerned about is CHF, fluid overload. Assessment findings: not always do you hear a heart murmur, and it is confirmed by an echocardiogram. Medical management is your diuretics, surgical if needed. Next one is necrotizing enterocolitis. It's a gastrointestinal disease that affects the neonates. It results in necrosis and inflammation of the bowel, and typically more commonly seen in the initiation of your enteral feedings. It may be up to 3 to 10 days where you start seeing this, and the baby starts showing signs of sepsis. So the baby's going to have tachypnea, see the baby going into respiratory failure, unstable temperatures, having signs and symptoms of shock, a very distended abdomen, bloody stools, vomiting, discoloration, and visible bowel loops. You're going to be treating it with antibiotics. Going to get your blood cultures. first, correct? Antibiotics, IV fluids, resting of the bowel, NPO. They may need to go in and do a bowel resection or a temporary colostomy. Next one is your retinopathy of the prematurity. And you're going to see that a lot with your babies with very low birth weight. Risk factors are exposure to high levels of oxygen. And the aim is to decrease any risk of blindness. Your post-mature are those born after 42 weeks. You're going to see that they have an increased risk for meconium aspiration, increased risk for hypoxemia, hypoglycemia, cold stress, polycythemia, and any birth-related traumas related to being the macrosomia or the larger birth weight. So basically the key thing to understand in your post-mature is the placenta is decreasing its function. So your assessment findings are really important. Dry, crack skin, they're not going to have the presence of the vernix or the lanugo like your preterm. The body's going to appear long and thin, and you may see meconium staining, fingernails, nail beds, umbilical cords, skin. We're going to be monitoring these babies for respiratory distress as well, administering oxygen as needed. So again, be really careful with the administration of oxygen with the retinopathy of prematurity. Although they are not premature, we're still concerned about retinopathy. Hypoglycemia, so we're going to be treating it just like that large for gestational, and monitoring their H&H for polycythemia. Signs of hypoglycemia: jitteriness, irritability, not feeding very well, and they may have those signs of RDS, the grunting, the lethargic. So you want to make sure, and if as long as they're able to suck and swallow and they're alert and oriented, feeding is the #1 way to manage a low blood sugar in a term, otherwise stable infant. Some nursing diagnoses of the post-term: hypothermia, imbalanced nutrition, impaired gas exchange, and ineffective peripheral tissue perfusion. And many of those we can see in our preterm as well, right? Care of the newborn meconium aspiration. And I showed you a video, I think it's on another slide or so, of that meconium aspiration. It's more common in your post-term. So that mom delivers and her amniotic fluid is meconium stained. They're getting that team ready. They're anticipating that baby's going to have some breathing difficulties. And meconium aspiration, like I said before, can increase the risk for bacterial pneumonia. Clinical manifestations: breathing difficulties, fetal hypoxia in utero or a few days post-birth, presence of signs of distress, listening to the lungs, hearing rales and rhonchi, and that visible staining of the meconium. Going to be diagnosed by a chest x-ray, listening to the lungs. It may result in metabolic acidosis, respiratory distress, and extreme hypoxemia. Therapy is pretty much similar to your respiratory distress. Resuscitative efforts as needed, transfer to the NICU, decrease tactile stimulation to decrease, minimize respiratory movements, neutral environment. They may need to do umbilical arterial line for monitoring of ABGs, administration of oxygen, administration of surfactant, because a lot of times the meconium aspiration syndrome kind of inactivates the surfactant, so they may need to administer that as well. And obviously, if they're administering the surfactant, they're doing it via ET tube. if you need to watch this or you missed this, it's there for you. But I'm going to continue. But you do have that in your link. You're small for gestational age, or your IUGR. Your risk factors, we've talked about that before. So prenatal care or lack thereof, age, inadequate, education, living conditions, multiple gestation, primipara, maternal and diseases such as heart disease, substance abuse, sickle cell anemia, fetal factors, infections. Mom may be bringing in, the baby is getting via mom. Your torch infections, toxoplasmosis, toxoplasmosis, rubella, herpes. I've had very little coffee this morning, just FYI. Syphilis, congenital malformations, any of your chromosomal disorders, and your inborn error of metabolism. Small for gestational age, you'll see that in your preterm, your term, and your post-term, but it's commonly seen in women who smoke or have high blood pressure. Some complications of the small for gestational age. I'm not going to go through all these because we've been discussing these. I feel sometimes like a broken record when I teach these concepts, because a lot of the stuff that you see with the preterm, you see also with your small for gestational age, your IUGR, and even some of your post-terms. Risk for cold stress increases. The smaller the newborn, the higher the risk. Always keep that in mind. Nursing actions are to assess and treat for RDS, maintain a neutral thermal environment, and decrease risk for hypoglycemia. And do I sound like a broken record by now? Care plans, revisiting for that small for gestational age. I'll let you pause if you needed to go through this, but again, there's a lot of stuff we've been talking about. Just the key thing is watching for those signs and symptoms of hypoglycemia, and know that we're treating below 40, not your traditional adult, where we're treating them below 60. You're large for gestational age. Most common reason is maternal diabetes. Genetic predisposition. Males are more traditionally larger than females at birth. And transposition of the great vessels. A lot of times you'll see that infant is larger for gestational age. Your macrosomic infants, remember macro, large, micro, small, kind of help you remember that. Your macrosomic infants are more than 8 pounds, 13 ounces, and they run the same risks as your large for gestational age. Birth injuries is common, hypoglycemia is common, tremors from the hypoglycemia, the low sugars cause hypocalcemia, so their calcium is low, and you'll see tremors are obvious signs of hypocalcemia, especially in the diabetic mom. So care of the LGA, or the large for gestational, is just monitoring, treating for the blood sugars, airway, and any birth injuries. Care of the infant of the diabetic mom. Again, the biggest risk is low blood sugar. Also, large for gestational age. They may be they may be macrosomic or ruddy in color. You'll see that more common in certain ethnic groups. Your Native American, Mexican American, and African American, or your Pacific Islanders. And the excessive growth is considered to those high levels of the glucose that is circulating in the bloodstream. Common complications, I think we've talked about these. Hypoglycemia, hypocalcemia, when the calcium is less than 7. And I put hypoglycemia less than 45. I'd stick with that 40 and the check what the literature says between 40 and 45. Hyperbilirubinemia, hepatic immaturity. Birth trauma, we talked about that. Risk for polycythemia. and risk for respiratory distress and any congenital malformations such as the transposition of those great vessels. Clinical therapy would be monitoring those blood sugars hourly, treating, again, feeding is best, IV glucose if the newborn cannot maintain or take the oral feedings. GBS positive. GBS positive is the primary cause of neonatal meningitis and sepsis. So it's really important to screen mom between 35 and 37 weeks. And then mom is to be getting IV penicillin at least 2 doses prior to delivery. And what was I going to tell you there? I'm just reading here. 15 to 40% of all women are asymptomatic, which is why if they don't have prenatal care, they're testing them when they come in. And then I have the last slide. Revisit all the criteria for prophylactic antibiotic treatment on page 534. I would revisit page 534. So nursing actions is watch for signs and symptoms of respiratory distress, monitor those blood sugars, administer antibiotics as needed, and maintain standard precautions for the GBS positive. The next one is the congenital anomalies. So I gave you a list of the ones I want you to focus on. Cleft lip, cleft palate. What are you seeing in there? You're seeing that opening in the lip, if it's on a cleft lip or a palate. Tracheoesophageal atresia, failure of the esophagus to connect to the stomach. PKU, inability to metabolize the amino acid phenylalanine. Galactosemia, inability to metabolize the galactose. So in galactosemia, can this baby be breastfed? Yes or no? No, correct, because this baby cannot metabolize glucose. Spinal bifida, there's several different types of spinal bifida. What I want you to know is it's a protrusion of the meninges. And Down syndrome is the basic facial features that you would note: the flat facial profile with a smaller nose, protruding tongue, semitic crease, and hypotonic muscles. And again, that really, there's a spectrum, whether it's very minimal or very obvious. And there is some pictures of some of the anomalies we talked about. Remember, patient-centered care. So key, again, let's go back and not forget about those parents that are attached to this. So you want to make sure you're encouraging the parents to hold, touch, and talk to that newborn. Can provide consistent care, give them resources, information, education. So the cleft lip, the key things here is watching for signs of dehydration, teaching the parents about how to feed, positioning, clearing any secretions, suctioning gently, and preventing any infection until the baby can go for surgery. There's a little video on cleft lip feeding. I would go back and revisit that. I think I told you that in class as well, and also with PKU. Galactosemia, so the baby is going to be given a specific type of formula. So breastfeeding is contraindicated. Spina bifida, you want to make sure you're protecting that protrusion with a sterile covering and plastic to prevent it from drying, and assessing the newborn for increased intracranial pressure, prevent from any infection, especially when changing the diaper. And any questions, that covers everything. Any questions for chapter 17? All right, well, if you don't have any questions, feel free to put them on the Q&A, and that is the end of chapter 17.